are preferred because they don't raise the IOP when you're dealing with something which you don't know whether there's a penetration or not. And the deeper they can take the plane, many times the anesthetists tell you, doctor, if it's going to be only a short time, I will not intubate. I'll simply give IV propofol and we'll manage. Please ask them to intubate. You don't know, number one, how long you're going to take. Number two, the deeper they take the patient under, it's that much better for you because the eye becomes soft and your working becomes much easier. Local anesthesia can be given if it's an adult in small lacerations, but otherwise you prefer GA. Coming to the corneal abrasion itself, most of the time the patient will tell you exactly when it happened. At 3:58 last evening, a leaf scratched my eye. So they will give you exact time. The only fellows who won't give you exact time without being called liars are those who are welders. Typically when we were residents in KM, we had patients who would finish a shift and the shift would be an afternoon shift, but they would come back at about 2 in the morning with corneal abrasion. And the welding shift had finished much earlier because it takes that much time because of hypoesthesia for them to start realizing that they have an abrasion. And contact lens, whereas again the same reason, because of hypoesthesia, they may have removed the lens at 2 o'clock in the afternoon but may come to you at 2 o'clock in the night. So don't take a patient coming to you with simple abrasion, don't take it lightly because the abrasion can still mask a deeper injury as well. Treatment, cycloplegia, any large abrasion, don't be afraid to give a cycloplegic. I remember Rajesh Khanna coming over to the clinic when I was a small child with abrasion during Hathi Mere Sathi shooting in Chennai. And he was miserable because for 2 days he had been patched up in Chennai. And when he came, it was a fairly large abrasion, almost 3/4 of the cornea, so I have been told, had abraded. All that Dr. B.T. Maskar did was put a drop of atropine. So don't be afraid to use cycloplegics even in something as simple as an abrasion because the pain relief that the patient will get is tremendous and it will help once the spasm goes away, the photophobia goes away. Topical antibiotic is always useful. Remember that preservatives can retard healing, so not too much. If it's not infected, don't go overboard with 1 hourly topical antibiotics. Discourage topical anesthetics because they can cause blindness because of reduced corneal sensitivity and infections. To patch or not to patch is the question. Both the things that you do are right, provided you have a close follow-up on the patient. Patch, the advantage is that there is reduced discomfort, it eliminates blinking, so it promotes the epithelial healing. But the disadvantage is that it increases the corneal temperature inside. So if there is any infection, the chance that the bacteria will just love the patch is great. So if you suspect infection, you would be better off not patching. If you think it's a clean wound and there is no infection, you can put some chloro antibiotic, Applicap or whatever and patch and call the patient. If it's a small abrasion, clean wound. Otherwise, it's much better not to patch and put the patient on hourly lubricants and maybe 3-4 times a day drops if you feel it's a clean wound. Otherwise, you can increase the frequency of the drops. Bandage contact lens is a somewhat compromised solution between patching and no patching. It's more comfortable, allows vision, but it also delays the healing like in a... While we are on the subject of abrasions, I thought I should also share with you a little bit about a trivial trauma which can result in something called a recurrent erosion syndrome. This can of course occur also because of basement epithelial dystrophies, but in the context of an ocular trauma meeting, one must bear in mind that trivial trauma can result in something which is a painful injury which has even driven patients to want to commit suicide. So it's episodic with symptom-free intervals usual. Typical early morning they wake up suddenly with pain, foreign body sensation and watering, and the attacks vary greatly in pattern and intensity. And sometimes because of this they are afraid of even falling asleep because every time they go to sleep with the REM movement, rapid eye movement, the eye blinks and the epithelium is cast off and they get up with pain, redness and watering. Diagnosis is not very difficult during an attack. You might sometimes, if the patient comes to you during the attack, if you practice at 5 a.m. in the morning, then you might even see a recurrent erosion like this. But if it's a window period, in the history is typical, don't dismiss it as being functional. Ask the patient to return immediately. Sometimes it lasts for 24, 48 hours and you can see this. There's really not too much that you can do with this. Hyperosmotic ointments or a bland lubricating ointment can be given. Patching, bandage contact lens during attacks. And avoid topical steroids because you can increase the chances of infection. Look for associated dry eye in these patients and treat appropriately. The surgical treatment of this is, once you've been able to find it, make a chart, a diagram, and draw the abrasion area so that you know where it is. Simple debridement. Remove epithelium around it as well. Remove epithelium around it as well so that new healthy epithelium from far away can come and repopulate. A superficial keratectomy, or you can do an anterior stromal puncture. Just take a needle, bend it, and dip it inside such that you don't penetrate every time, but go up to mid-stromal level. So that the epithelium can get reinforced, it can grow roots as it were into the stroma and hold on there. And you could do the same thing more fancily and charging more with a YAG laser. And if you want to charge still more, you can do a phototherapeutic keratectomy. It works very well. Remove this epithelium even mechanically and remove some amount around it as well. And then apply pounding spot size lasers in the peripheral area. So you will excite the epithelium from outside to come in. It works fairly well. Corneal foreign body removal, remove the take-home messages, remove every foreign body. Don't leave them there because they can retard healing. Post-op, treat every corneal injury as potentially infected. You can get infections, hyphema, wound leak with even trivial foreign bodies. Long-term goals is mandatory use of protective eyewear. At some point, Dr. D.K. Mehta will join us and tell us something more about this. Educating parents and children about the hazards of eye injury, promoting eyewear for kids, and in blind eyes, giving cosmetic rehab with tattooing or cosmetic contact lenses. Thank you very much for your attention.
Thank you, Dr. Quresh. I would request.
Can I ask a question? Sure. Dr. Muscati?
I showed one slide. I showed a picture like that. Many times you get a blast injury, you get about 20 or 100 foreign bodies in the eye. Whatever you can remove, but keep the patient under close follow-up. Call again and again. And some of the patients we have done lamellar keratoplasties.
Okay.
To get rid of, if most of them, because most of them are superficial, so you can do a deep lamellar keratoplasty and get rid of them in worst case scenarios. But most of the time you can get by with just removing them. They keep coming up, becoming superficial, and remove it. Call them again after a week, 2 weeks, again a few come up and remove. But don't cease your follow-up on the patient till the last foreign body is removed.
But usually we cannot remove all of them.
Whatever, as much as you can, yeah.
Thank you.
Thank you.
Thank you, ma'am. I thank the local organizing committee for inviting me over here. I'll be just showing you the video films. I've got 3 films, and I'll just keep talking to you at the moment. There's a few seconds blank initially, and it'll just come up. 3 cases, and the first case is a simple corneal tear, and the way I have sutured, I think most of us are suturing in a similar manner. And this patient had a tear, and of course, just used the iris repositor to clear off the cornea from the lens matter and just trying to maintain the anterior chamber. And then, of course, I normally use a 10-0 nylon. I think most of us use the sewing sutures. I prefer to go ahead with the interrupted sutures because of the post-op. You tend to have probably a little lesser astigmatism